Assalamu alaikum wa rahmatullahi wa barakatuh. This is the second lecture of diabetes mellitus. Today we are going to speak about the terms frequently used when we are speaking about diabetes. The first term is honeymoon phase or فترة شهر العسل in patients with type 1 diabetes is a transient period where the blood sugar starts to go down and the need for insulin is reduced. This occurs in some patients with type 1 diabetes. It's due to the residual beta cells will restart functioning and secreting insulin for a short period of time until they are destroyed again completely. The other term is stress hyperglycemia. Stress hyperglycemia is hyperglycemia that occurs in people with severe stressful conditions or during pregnancy or during severe sepsis and myocardial infarction. This will fade or go away and return back to normal glycemia when the stressful condition or the causative thing disappear, but those patients are susceptible to develop future diabetes. Therefore, they should be followed regularly. What are the classical symptoms of diabetes? As we all know, they are polyuria, polydipsia, polyphagia, weight loss and emaciation, tiredness, uneasy fatigability, repeated nausea and vomiting during hyperglycemia, blurred vision, slow healing of wounds and infection, impotence in men, etc., etc. How do patients with diabetes present? Type 1 usually is acute, as is mentioned in the previous lecture, and they present or appear during a short period of time. Their presentation is either in the emergency room with ketoacidosis or with the classical symptoms mentioned before that not responding to conventional treatment, or sometimes they present with severe abdomen mistaken as acute abdomen. While type 2 diabetes usually is insidious and develops symptoms over a long period of time, and the condition is diagnosed usually with complications because of longer duration of undiagnosed diabetes and not controlled diabetes. They will develop complications as retinal or renal or neural. So they present complaining from blurred vision or renal problem, and they are incidentally diagnosed of having diabetes. Others give long history of easy fatigability with no osmotic symptoms, and they present sometimes with complete beta cell dysfunction that require insulin. Others will stay undiagnosed for their life, and they are about 25 to 50% of patients with diabetes, especially in the underdeveloped world. How to differentiate between type 1 and type 2 diabetes when they first present to your clinic? Age of onset is usually below 40, while in type 2 is above 50. The durations of symptoms are acute, days to weeks, while in type 2 diabetes, months to years. Body weight is either normal or low, as we mentioned, emaciation, while in type 2 diabetes is usually obese. Autoantibodies is positive in type 1, while negative in type 2. Complication of the diagnosis, usually type 1 diabetes, they present with no complication because it is acute and there's no time not enough time passed for the development of complication. while type 2, as we mentioned, 25% of them may present with complication. Family history, negative or uncommon in type 1, while common in type 2. Presence of other autoimmune diseases is common in type 1 diabetes, uncommon in type 2. DKA or ketoacidosis is common in type 1, especially if they don't use treatment or diagnose for the first time. In type 2, it may occur, but it is not common. How we are going to diagnose diabetes? If a patient with diabetes or suspected diabetes presented with the classical symptoms mentioned before, only one of the following investigations. If positive, then you have a solid diagnosis. That's why I use the word or. So, classical symptoms, one of the following three positive, then the patient is diagnosed. But if the patient came with no symptoms of diabetes, and incidentally, one of the above three investigations was positive, then it should be repeated to confirm or solidate the diagnosis. The diagnosis of gestational diabetes, as we mentioned in the first lecture, is the diabetes that occur at 24 to 28 weeks of pregnancy with no history of upper diabetes before pregnancy. Then one of the following plasma glucose values, if exceeded, then the patient has gestational diabetes. Fasting more or equal to 92 milligram per deciliter. 1 hour postprandial above or equal to 180 milligram. 2 hours postprandial 153 milligram, more or equal to 153 milligram per deciliter. Pre-diabetes أو ما قبل الدايابيتس is unimpaired fasting glucose or impaired postprandial glucose or both of them. It's important, in spite that the blood sugar levels are below that of over diabetes, is that it's associated with high risk of future development of diabetes, cardiovascular disease, and they are usually associated with obesity, dyslipidemia, and hypertension. Criteria for the diagnosis of prediabetes: fasting is between 100 milligram to 125. 2 hours post glucose tolerance is between 140 to 199 milligram per deciliter. Hemoglobin A1C is 5.7 to 6.4%. See, it is very obvious that they are below the levels needed to diagnose over diabetes. So they are called pre-diabetes. Investigations that are usually used in the diagnosis and management of diabetes: urine testing. Before 30 years or more, they used to look for glucose in the urine using test tapes. But nowadays, this is omitted and only used for screening tests if needed. That's because the urine threshold for glucose secretion is different from person to person, so there is no standard value to diagnose diabetes. The most frequent other cause of glycosuria is a low renal threshold, which is during pregnancy and in young age. Other things that we look for in the urine are proteins. If we find microalbuminuria or macroalbuminuria or protein in the urine, then we can diagnose as diabetic nephropathy. Also, we look for ketones in the urine, because ketone in the urine is either due to starvation, fasting, or severe exercise, or if associated with nausea, vomiting, classical symptoms of diabetes and hyperglycemia, then it is of DKA. So DKA should be strongly considered when there is ketones in the urine. The blood. The blood is very important to measure the glucose, and this, when we measure the glucose in the blood, we should consider when the patient has had his food or meal. The time is used is fasting blood glucose or 2 hours postprandial or glucose tolerance test. The fasting blood glucose should be measured 8 to 12 hours overnight, 2 lines under overnight fasting. The glucose concentration is lower in the venous than arterial and capillary blood. Whole blood glucose concentration is lower than plasma concentration because RBCs contain relatively little amount of glucose. Venous plasma glucose value are usually the most reliable thing for the diagnostic purposes of diabetes. Ketones. Ketones are also measured in the blood, diabetic ketoacidosis, and they are very important to monitor the resolution of decay. The ketones found in the blood are acetones, acetoacetic acid, and beta-hydroxybutyric acid. Glycated hemoglobin. Glycated hemoglobin provides an important and objective measure of glycemic control over the last 3 months. It decreases in patients with anemia, pregnancy, and difficult to be used when there is uremia or hemoglobinopathy. It is helpful by being measured at any time of the day, and the patient does not need to be fasting or having meals. Interstitial glucose. It is an increasingly used way of measuring glucose by the patient themselves, and it's called continuous glucose monitoring using a tiny sensor inserted under the skin to measure glucose. Management of diabetes. Cornerstone of diabetes management are healthy eating, exercise, monitoring, our continuous self-monitoring, medication, and education. That's to say, when a patient with diabetes comes to you, it's not just giving him treatment and tell him to go home. You have to educate him about lifestyle changes, healthy eating, how to do exercise, how to self-monitor himself, and then how to use his medication. Our goals of management is to maintain as near as possible a blood glucose level, eliminate or treat symptoms related to hyperglycemia, as mentioned before, polydipsia, weight loss, polyuria, polyphagia, etc. Reduce the short-term and long-term complications. Allow the patient to live as normal life as possible. What is our target of glucose level? This is different from one patient to another, depending on the patient age, presence and severity of complication, presence of other medical comorbidities, patient preference, and cooperation. Now we are going to speak about the diet. The diet of patients with diabetes should be balanced and constitute carbohydrates, fat, proteins, fruit, and vegetables. The carbohydrate amount should be 45 to 60% of the total calorie need. 10% of it should be high fiber carbohydrate. The fat should be not more than 35%, made of polyunsaturated less than 10%. هذا زيت الزيتون العادي اللي بطالع نستعمله ببيوتنا. والمونو unsaturated 10 to 20%، واللي نقصد به مثل زيت الزيتون الجيد العصرة الأولى على البارد، and الزيت الموجود بالكرزات كالفستق والفستق حبيب etc. الساتوريتد less than 10% وهو الدهن الجامد. The protein requirement in the diet of patients with diabetes should be between 10 and 15% and not to exceed 1 gram per kg per body weight per day. The fruit and vegetables is about, daily need is about 5 portions, and each portion weight 80 gram. The exercise. Exercise include walking, working in the garden, swimming, riding a bicycle, and the amount needed in patients between the ages 18 to 64 years should be 2.5 hours of moderate intensity exercise or 75 minutes of vigorous intensity exercise. Older adults, if they can do these exercises, they should be encouraged. Pharmacological therapy. Pharmacological therapy, before we start anti-diabetic agents, we should consider to treat the complications if were present when the patient presented, especially in patients with type 2, or the other associated comorbidities as obesity, hypertension, dyslipidemia, and cardiovascular disease. The target for blood pressure is below 140 to 90, that's to say 130/80, and can be treated more aggressively or vigorously in certain complications of diabetes. For lipid lowering, statins should be used and recommended for anyone with diabetes who is over the age of 40, irrespective of the baseline cholesterol level. Because the problem here is not the level of cholesterol, but the type of cholesterol that is present in patients with diabetes. It is also recommended for those with ages less than 40% with additional atherosclerotic cardiovascular risk factor. The aspirin is recommended at a dose of 75 to 162 milligram per day as primary prevention in those with type 1 or type 2 diabetes who are at increased risk of cardiovascular disease. This involve or include most men or women with diabetes aged 50 years or more who have at least one additional major risk factor as family history, premature sclerosis, cardiovascular disease, hypertension, smoking, dyslipidemia, or albuminuria. And we should consider if he has any risk factor of GI bleeding, because as we all know, aspirin might cause GI bleeding. Treating type 2 diabetes. In patients with newly diagnosed type 2 diabetes with severe symptoms and or high blood glucose level or hemoglobin A1C should be treated aggressively on their first visit. That's to say, start either insulin or insulin secretagogues that are going to be mentioned in the next lecture. If the patient presented with moderate to mild diabetes and not that increase in hemoglobin A1C, then we can follow the following steps. First, we start with diet and lifestyle changes and follow the patient up to 3 months. And if there was no response or the blood sugar was increasing, then we can add metformin as monotherapy. So the next step, lifestyle changes, diet, and metformin up to 3 months. Also, if there was no response or the blood sugar continued to increase, then we can stop and add another drug. So for another 3 months, this could be one of the following: thiazolidinedione, DPP4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, or basal insulin. All of these drugs will be mentioned in the next lecture. If this step also failed, then we can add another third drug, and if this also failed, then we can change to insulin alone.